Good morning, everyone. I'm Mark Weeks, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Harm Reduction, Substance Use, and Infectious Disease Prevention During Crisis with James Kowalski. This webinar is being made available through a collaboration of the Florida Department of Children and Families Office of Substance Abuse and Mental Health and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and those options are posted in the chat panel too. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be made available on the FATA website within 30 business days. A helpful hint, the archive video displays what looks to be an error message but is only a delay buffer. Ignore it, hit play, and enjoy. To access the recording and PowerPoint, go to www.fata.org, Resources Center, Training Library. FATA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where personals can maintain statements of credit for webinars, workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FATA website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FATA as part of registration remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes in the individual personal development journals for persons completing the evaluation and attending the full webinar. Completion of the evaluation is necessary to receive CE credits or to access your statements of credit. Do note that the evaluation will close on midnight on Thursday, November 19th, 2020. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and the Mental Health Counseling, and for persons accreditations through the Florida Certification Board. If you are a licensed healthcare professional, be sure to include your Florida license numbers for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you do not need to provide your certificate numbers when you register for our site. Note, please, that WebEx monitors arrivals and departures of attendees and provides a report upon completion. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the webinar, the entire webinar. We are not permitted to provide partial credit. And now for our presenter, James Kowalski is the project director for SAMHSA's funded grant to prevent prescription drug and opioid overdose deaths at Illinois Department of Human Services in the Division of Substance Use Prevention and Recovery. He serves as the Drug Overdose Prevention Program Coordinator and provides support to overdose education and naloxone distributations provided through the state of Illinois. Since 2013, James has been providing training and technical assistance to organizations adapting practices to incorporate harm reduction, housing first, motivational interviewing, and trauma-informed care. James and his wife, Susie, provide training and consultation through their company, Practice for Progress. James is a member of the Motivational Interviewing Network of Trainers, MINT. He received a Master of Arts degree from the School of Social Services Administration at the University of Chicago. James is committed to promoting a shift in public policy and service delivery that is characterized by acceptance and respect for people who use drugs, have a substance use disorder, or are in recovery. And now I'd like you to welcome our presenter, James. I will turn the presentation over to you.
Great. Can you all hear me?
Yes.
All right. Thank you so much for that introduction. And thank you to FATA for bringing me back. And thanks to Mark and Karina and Eric, who are all going to be working behind the scenes today to make sure this webinar goes smoothly. So we are here to talk about harm reduction, substance use, and infectious disease prevention during crisis. And I will just say, for those of you who know me, you might know a few things about me. One is I'm very passionate about harm reduction. And I'm also originally from Florida. So doing this webinar today does help me feel a little bit closer to Florida. Not quite the same thing as being there in person, obviously, but there's a lot of family who I haven't been able to see in quite some time because of the ongoing pandemic and crisis that we're facing right now. So yes, it is great to be talking to some folks who are back home in Florida. And, I will also just take this moment to sort of acknowledge, because of the ongoing crisis that our country is facing right now, it takes what is already a very challenging job for all of you and makes it that much more complicated. The day-to-day of your jobs, but also I think managing our own personal lives has become more complicated because of the COVID-19 pandemic. I just want to sort of acknowledge up front that really does complicate things in a way that is, unique and something that none of us have really had to face before. So we'll have some time at the end of the webinar to sort of talk a little bit more about COVID. But for now, here's my contact information. You can reach out to us at practiceforprogressinc@gmail.com or on our website. I already got a pretty thorough introduction, so I won't go into any details about my background here, and we'll just get started with the webinar for today. So here's some of the objectives. Overall, we're going to explain the value of harm reduction services for engaging people who use drugs and also promoting their health and safety during the COVID-19 pandemic. And really, so much of it goes beyond just, during the pandemic as well. And then we're going to talk specifically about some of the risk reduction strategies that prevent the spread of infectious diseases when using substances. And so here I'll just draw a distinction between, both there's sort of a harm reduction approach to services, and part of what harm reduction tries to do is promote and help people implement risk reduction strategies. And so the strategies are things like, using sterile substance use supplies like sterile syringes when you're injecting drugs that many of us are familiar with. And then last, we'll describe the ways that harm reduction and substance use treatment services are adapting to account for the COVID-19 pandemic. So, a lot of what we'll do today is, we'll talk sort of broadly about harm reduction up front, and then we'll get into some of the details about some of the more common infectious diseases that people who use drugs are at risk of exposure to. And then we'll kind of round things out throughout, I would say, with some discussion of harm reduction strategies and adapting to COVID at the end of the presentation. I'll just encourage you all, there is the chat box on the side. There's also a Q&A box, and I'll be keeping an eye on those as we go throughout the webinar today. So feel free to just chime in. You don't have to hold your questions or sit on them, just as things come to you. I know for me, chatting and asking questions is a way of staying engaged during presentations. So if that helps you stay engaged, please make use of those things, and I'll keep an eye on those and try to respond as things come up. And then also keep an eye out for polls. We do have a few polls sprinkled through the presentation today, so you'll want to keep an eye out for those as well. And with that, I'm going to get us started. So, where I want to start off is, when we think about substance use, I think for some of us that seems like a pretty natural thing to be talking about infectious disease when we're talking about substance use. But I do think it's important to upfront address, why are we talking about physical health, among substance use treatment providers. And, I think of if you've ever done intake assessments, you've probably had someone stop you at some point when you get to the section about physical health conditions, and they say, I'm here to talk about my substance use. What does it matter if I have, diabetes, or if I'm taking, medication for, for hypertension? And as we know, there's a good reason to talk to people about the biomedical conditions, right, and complications. That's right there in the ASAM dimension too. And so we talk to people about their current and their past physical health conditions. And so I'm curious to hear from you all, why do we ask about physical health conditions? What do you all see as the value or the importance of asking about those things? And you can go ahead and respond using the chat box. So while we wait for some, responses to come in, I would say just, part of the basic function of asking about this in the ASAM criteria is really to just know and identify any needs for physical health treatment that people might have that either are met or unmet at this time. And in that way, I see accurate assessment and consistency. Yeah. And I would say actually, so that I like that you used the word consistency there. I see consistency as sort of one of the things that we can help and will sort of come up throughout the different infectious diseases is the idea that we help people maintain consistency with their physical health conditions and their physical health treatment as counselors or as case managers or community health workers, peers, and kind of helping to keep people on track with maintaining their physical health. I see whole health is important. And yeah, I really like, in looking at this, you see sort of the idea of a holistic approach to substance use. Whole health, assess risk. I think also, are they medicating by drug use pain and neglect in there? Are they medicating by drug use? So I think that's also interesting because, again, understanding someone's physical health conditions may give us a sense of what they're already sort of, in a sense, using substances to treat in their life and what things might need to be replaced, right? What prescription alternatives might exist or what, other healthy activities might replace substance use in their life. These are all really great answers for sure. I see more about kind of, self-medication, essentially, keeping the holistic health. So yeah, I think these are all like, you're all really like hitting on some of the key points of why we ask about this stuff. And then also, right, physical health can impact their substance use. So I think that's a really key idea here also is, we are acknowledging that physical health plays a role in the person's recovery. And I hear that in a lot of the different comments that are coming in right now is, your physical health conditions can impact your ability to make changes with your relationship to drugs. And I mean, even just on a pure standpoint of, it makes it harder to, if you're dealing with physical health conditions, it may make it more difficult to get up and get out of bed in the morning. It may make it more difficult to move around and get to, to outpatient counseling sessions. It might make it more difficult to manage your calendar and keep appointments straight. So there are just sort of a number of ways that having physical health conditions can complicate just the logistical aspects of seeking out treatment. But then I think also some of the people have sort of touched on the idea that it can also, be a factor in terms of why we might be using drugs or what we might be trying to manage by using drugs, I should say. So yeah, I think we start to get a sense of, we understand that these are really important aspects of a person's whole health, just like someone's substance use is an important part of their whole health. And just like it is an important part of someone's substance use, I would say it's also an important part of someone's recovery to take into consideration what their physical health conditions are. So here, SAMHSA acknowledges in their working definition of recovery that positive health outcomes or changes are an important part of someone's recovery. You see here, recovery is a process of change through which people improve their health and wellness, live a self-directed life, and strive to reach their full potential. And they identify 4 major dimensions, one of which is health. And they define health as overcoming or managing one's diseases or symptoms and making informed, healthy choices that support physical and emotional well-being. And again, I think just a few people touched on this idea of holistic health, right? It's when people come to a substance use treatment program, they're not necessarily just looking for a way to work on abstinence or a way to stop using drugs, right? The idea is, maybe they want to stop using drugs, but more so that is really a step in the process of making all these other positive changes in their life. And I think this working definition of recovery really hits on those other things that we might be working on with people to help them pursue. And again, I think it's also really helpful to talk about physical health as broadening the menu of what we want to work on with people. And again, I'm thinking again of doing intake assessments, or if you've ever worked on treatment plans with people and you ask them, well, what do you want to work on? And they say, well, I don't know. Or they say, I just want to stop using. It's like, okay, right. But maybe why do you want to stop using? What do you think that will change about your life? And talking about health and some of these other ideas too about purpose and community help sort of lay the roadmap of how we can work together with people. So here's where I'll bring in the idea of harm reduction. And I imagine many of you all have been exposed to harm reduction in one form or another. But I do think it's helpful to sort of set the table in terms of when I talk about harm reduction, some of the key ideas that come up for me and that are really essential parts of doing harm reduction work. So here you see the definition. Harm reduction is a set of pragmatic and compassionate approaches for reducing harm associated with high-risk behaviors and improving quality of life for individuals and their communities. A couple things I'll just pull out there. You see the idea of high-risk behaviors. And so while we think of harm reduction as, and it is true that harm reduction really did, it was developed from the experiences of people who use drugs, right? People who use drugs, helping each other, realizing things that they could do to keep themselves safer. Really, I think it also kind of connects to the idea of mutual aid, but the idea of people who use drugs helping each other. Now we've sort of taken some of those same concepts and ideas that grew out of that work and really expanded it to working with people on any high-risk behavior or really any behavior change that might be important to them. So it's not just about the harm associated with substance use, and in this case, we might say it's also about the potential harm associated with managing your physical health. We would also talk about not just reducing the harm, but improving the quality of life, and I think physical health is a really good example of that, where improving someone's health can lead to positive developments in their quality of life. And then last, I'll highlight individuals and their communities. And I think this is especially pertinent when we're talking about infectious disease. And something we'll kind of come back to, or we'll see in a few different instances, is, when we reduce the incidence of an infectious disease in an individual, that also reduces the risk of exposure to the entire community. And so I think infectious disease fits really well with harm reduction work, because harm reduction is about both helping the individual and thereby also trying to take in the consideration and help the community itself. And then last, the other quotation here I wanted to highlight is, the premise of harm reduction is that by welcoming people as they are, by offering help that meets people's basic needs, we can increase client engagement and lower their reluctance to change. So again, here you see the idea of basic needs, right? Satisfying those basic needs. And I think obviously, physical health is one of the most basic needs that we have. We think of other things, maybe like someone's living environment or their home environment going along with those basic needs. But, I think here you see the idea that when you work with people on the things that they want to work on, when you start from the goals that they have or from the needs that they identify for themselves, that actually brings more people in, and it actually opens them up to the idea of making changes, right? That the easiest way to make change, and I think this is very true from a harm reduction perspective, is not to take on the biggest, most challenging thing right away, but to take on the things that we know we want to change, we feel maybe confident that we can change, and start taking the steps to address that first. I'd say with harm reduction, it's also important to acknowledge there is no denial here that drugs or really any risky behavior can cause harm in someone's life. But we also acknowledge when we're doing harm reduction work that there is a spectrum here. And with any activity, there are more risky or more harmful ways of engaging in a behavior or engaging in substance use. And then there are also safer ways to engage in substance use. And even just taking, the simple example of, substance use and managing physical health is, I worked with someone who was a heavy alcohol user who had hypertension and got prescribed medication for his hypertension that he was able to take in spite of not wanting to make any changes to his alcohol use. Would it be better for his physical health if he decided to stop using alcohol or cut back on alcohol? Sure. But again, this goes back to that idea you might hear, like, better is better. It is better that he's taking medication for his hypertension, even if he's not ready to start addressing his alcohol use yet. Here, I'm talking a little bit about, taking some of these like broad definitions and generalizations about harm reduction and what do they look like in practice. And when we say harm reduction in practice, I think most often people just think of a syringe service program. And that's fair because, many of the programs that self-identify as a harm reduction program, they offer syringe access among another, range of services. But a lot of these harm reduction principles, you'll see these are generalizable things that really can be applied in a variety of service sectors, including substance use treatment. So I'll just kind of go through some of these key points here. So, low threshold to access services. That means as much as possible, we don't want to put up a lot of barriers. We want to help people get their foot in the door when we're doing harm reduction-based services. Integrating a biopsychosocial approach to substance use. Again, this overlaps really well with what we were talking about before about the idea of a holistic approach. It recognizes that it's not just one aspect of a person's life that contributes to their relationship with drugs, but that there are also, individual factors like their maybe their mental health condition or just sort of the stressors in their life in terms of their mental health in that way as well, not just a diagnosed mental illness. It could be the environmental factors in their life that are influencing their substance use, and in that way, that's why we ask about recovery and living environment. Again, here, the next point, so treating people with respect and avoid shaming, and it's sort of an essential part to how you work with people. And I think something that people who use drugs are so unfamiliar with really is the idea of being respected and not just put down, right? And if you've ever tried to engage someone in a way where you treat them with respect, it's almost like they're caught off guard by it, right? They expect you to put them down. They expect you to, just tell them what to do. And I think that says something about the environment that we've created around people who use drugs. And I think that actually makes it a lot harder to pursue any changes. Harm reduction does not use predetermined goals or interventions. So I think here, we hear a lot about the idea of, using a person-centered approach, or sometimes a client-centered approach. And I think, in harm reduction, it's very much about being person-centered, not just in terms of, I think sometimes person-centered can be mischaracterized as, well, what do you think is the best way to quit using drugs, right? Until the person identifies complete abstinence as their goal, we don't want to jump ahead there. And I think, again, this goes back to the idea of letting people set the agenda. And again, one of the things that can help with setting that agenda is really expanding the menu of options. So, a harm reduction program might offer other services, like I mentioned before, in addition to syringe access. They might offer clothing and food or flu shots and vaccines. And some of these services you also might offer in your treatment programs as well. And again, that's why, even if you're just doing counseling with someone, it's not like the only thing that you can talk about in that person's life is their substance use itself, because so much of what's going on in their life can affect their relationship with drugs as well. And then last, supporting any positive change is one of those mantras of harm reduction where, instead of pushing people to make more significant changes, or instead of, when people are making efforts and making changes, sort of putting them down and saying, oh, it'd be better if, right? Or, that type of mentality of, it never feels like it's good enough for someone. We try to get away from that, right? In harm reduction, you really want to embrace the fact that people are making changes, because like we said before, we know that those first small changes are really indications that this person is in the process of making changes more broadly in their life. And I'm just going to highlight one of these comments here. So the client must drive the therapeutic process of abstinence and substance use treatment. And I completely agree with that. And I think harm reduction would really embrace that idea also. And I think also important here to acknowledge, I think sometimes harm reduction gets cast as being opposed to abstinence. And I think the challenge for substance use treatment providers is many of the people who you are serving are going to come in seeking abstinence. That doesn't mean that you can't use a harm reduction approach to helping them pursue the goal of abstinence. So I think that's an important thing to kind of keep in mind here. And then one more comment here. So asking what their highs and lows were for the week or for the month is helpful to see if there were any triggers that were addressed in the intake. Yeah, so I think, again, part of the function that we serve as counselors and in substance use treatment programs is to kind of be a sounding board and a way of sort of checking in about people's overall health, and that includes their emotional health. I'll say, just as sort of a summary of these things, I see as some of the key concepts here in harm reduction in practice, the idea of acceptance, accepting people as they are, curiosity, right? And I think you hear that curiosity in even just checking in with people and not only allowing them to set the goals and the strategies that they pursue, but also being curious about what's happening in their life, and then really being creative with them about all the different ways that you can help them pursue positive changes in their life. So I put this on here. This is from SAMHSA's National Survey on Drug Use and Health. We know that there is a significant treatment gap in the United States of America, that something like only 10% of people with a substance use disorder receive any type of specialty treatment. And so this table, like I said, comes from NSDA is the acronym here. And every year they ask people who need treatment, right, have a substance use, would qualify as having a substance use disorder, but did not receive treatment in the past year. Why is it that you didn't receive treatment? And, among some of the barriers, it might be hard to read some of the text on here, but among some of the barriers people identify are, inadequate healthcare coverage, or the stigma that's associated with seeking out help, right? I don't want my neighbors to find out. It might affect my job, those types of concerns. But consistently, the top reason given each year, if you look across the line where the arrow's pointing, is that people just are not ready to stop using. And around 40% is where this number hovers each year. But around 40% of people who, have a substance use problem and would acknowledge that they could use some help with it, don't go to treatment because they're not ready to stop using entirely. And that's a pretty significant portion of people who really could benefit from treatment and from the types of support and care that are offered in substance use treatment programs, but are avoiding it because, when they hear treatment, all they think about is not using altogether. And that high threshold that they perceive, whether it's there or not, but that perception of a high threshold to accessing care really keeps a lot of people from ever walking in the door. And so that's where I think harm reduction can be really valuable, is how do we find that 40% of people and say, hey, if you're not ready to stop using, we're going to open the door for you anyway, because we're a place where you can work on your emotional health, your physical health, and if you want to make any changes around your substance use, whether it be abstinence or not, we're going to support you with that. So that brings us to our first poll question, and I think Karina is going to pull this up for you. Excuse me. So you should see the poll question over there on the right. So I'll give you a minute or so to answer. The question here is, does your program currently work with individuals who do not identify complete abstinence as their goal? So, if somebody comes in, for instance, and perhaps they want to moderate their substance use, or I know I was in a treatment program one time where somebody came in and they wanted to abstain from using cocaine, but did not want to make any changes to their cannabis use. And the staff really struggled with, should we offer help to this person if they're not ready to completely, pursue abstinence of all these mind-altering substances. So I'll give you a few more seconds to respond in there before we close. But, I think something that just like while we're thinking on this, what I would say is, as I mentioned before, we know there's more to recovery than just abstinence. We've talked a little bit about, meeting people's basic needs and having a holistic approach. So we can do those things for the people we're working with, right? But if that assistance is really only available to the people who are, I guess that's the question, is are we only offering that assistance to the people who are going to name complete abstinence as their goal? So it's been about a little over a minute, so I'll say we can go ahead and close the poll now, and we'll see what the results look like. And so it looks like, among the people who responded, the vast majority are saying that their program does currently serve people who do not identify complete abstinence as their goal. About 73 of the 86 respondents said that they do work with folks in those circumstances. So for those who responded, yes, I'm curious, what does that look like? And I think, especially for the folks who aren't already working with people, or right, for the other folks who responded to the poll who right now can only work with people in their program who identify complete abstinence as their goal, what would you say are some of the challenges and benefits of working with people who come into the door but aren't ready to pursue complete abstinence as their goal? The comment here, respecting the client's honesty. And I think, it's an interesting thing because, by saying up front, look, your goal does not have to be complete abstinence. That is really, if that's what you want, we will help you with that. But really, we're here to help you with whatever you identify. I really do think harm reduction and that type of more open approach does set the table for honesty, right? We know that having someone who you can safely and openly communicate with in a therapeutic relationship is an important part of that recovery process. And so even just having someone who you can talk honestly with about and saying like, hey, I am still using and I'm starting to dislike it, right? Or I am still using and it's helping me in these ways. So the other comment here is so many lie about wanting to be substance free. And so that's a really interesting point, right? So even if you do not explicitly work with individuals who don't identify abstinence as their goal, you're still working with them, right? If you're in a program that says we will only work with people who identify complete abstinence as their goal, then you're going to get people who come in and say, yes, complete abstinence is my goal, even if it's not, and even if it's not what they're actually doing. So again, this idea of working with people at where they're at, and that there is no need to lie. And I think, this idea of working with people where they're at, it's a very common thing, I think, in helping professions to use that mentality. But I think this idea of, okay, well, what if where someone's at is not wanting complete abstinence? It really does challenge us to sort of push our boundaries in terms of what that idea of meeting people where they're at actually looks like. And then I think, again, this going back to the idea of really, to me, over and over, what I'm reading in a lot of these comments is that one of the real benefits of working with people from this approach is that you do get more honest conversations and more full conversations about what's happening in people's life. And you get to listen and hear about what's going on and do more of an honest exploration. Yeah, so thank you for these comments. And the idea of not having judgment, right, is so important here. And I think it's a little bit, in general, I think when we're offering substance use treatment services, we can say to people like, I'm not going to judge you. And if we set up the relationship as such where we say, well, you have to stop using drugs, and that's sort of the foundation of your relationship with someone, I think it does make it harder to feel like there is no judgment or that there isn't some sort of like push in a certain direction. So I'm going to keep us moving. Here's, when I was putting this slide together, I was like, this slide right here really could be a full day training in itself. But how do we integrate harm reduction into substance use treatment programs? And so I'm just going to give you 3 bullet points on what, under other circumstances, to be a very long discussion, but just to sort of get you thinking in the direction of, well, maybe there are some benefits to harm reduction. How do we get it to be a part of our program? Or if it is already a part of your program, like what else could we be doing? So, when you're working individually or in a group with people, you can incorporate harm reduction psychotherapy and the harm reduction approach into your substance use treatment programs. So some of the ideas that were on the harm reduction in practice. So, being person-centered, celebrating any positive change, right? Those are harm reduction principles that you can incorporate into your individual and group work with people. Building awareness of harm reduction interventions to reduce risks associated with substance use. So again, like we said, there are people who are not necessarily pursuing complete abstinence, whether they say that or not in our groups. And if you've been in a substance use treatment program long enough, you've definitely had people overtly tell you, no, I am not going to completely abstain for the rest of my life, right? And so I think sometimes the reaction to that, the appropriate reaction to that can feel like shutting that person down or making them think that that's a mistake and trying to, save them from going down that path. But I think instead, a more helpful approach is to sort of say, okay, let me meet you where you're at. If you're saying that as soon as you're done with probation, you're going to go back to using, well, what do you think you can do to keep yourself safer once you start using? And so I think that's where we can sort of start even teaching and talking about harm reduction interventions to reduce the risk associated with substance use. Probably some of you have worked with people with DUI cases, and many people who get a DUI do not want to abstain from alcohol for the rest of their life, even if that might be a condition of, their current case that they have on them. And so I think that's the question of, okay, if you are going to go back to drinking, after you've completed these DUI classes, what will you do differently in the future? And again, how do we talk about those types of harm reduction interventions and strategies with people? And then developing relationships with the harm reduction providers in your community. Again, I mentioned already, but I think too often there's this sort of distinction between the harm reduction provider and the treatment provider, as though we're not all really working on the same thing. Whether you're in a program that identifies as harm reduction or substance use treatment, we are all serving the same population. We're all trying to help people who use drugs. And I will say, if you work in a substance use treatment program, you have a lot more in common with someone who works in a harm reduction program than you do with someone who works, I don't know, in like accounting and financing or something like that, And in a way, harm reduction programs are really serving your potential future customers or your potential current customers, really. And then I think that also works in the other direction as well, which is if, for instance, like if I'm working with somebody and they're talking about going back to using once they finish their probation or whatever it might be, I really want them to know where the harm reduction providers are, because if they ultimately decide to go back to using, I want them to do it in the safest way possible. And I think even having that conversation with people really changes the dynamic, because oftentimes, the dynamic that I pick up on when someone is sort of digging in their heels and saying, I'm going to go back to using, I don't care about this stuff, right? The dynamic really feels like this one of like antagonism, almost like trying to test you and see like, well, are you going to fight me on this? It's like, no, I'm not here to fight you. I'm here to work with you, right? I'm your partner in you addressing these challenges in your life. And I think talking about, well, these are the harm reduction providers. If you are going to go back to using, these folks will be able to get you safe supplies if you do ultimately decide to go back to using. And if you decide you don't want to go back to using, like, we're here to offer these additional supports that might be beneficial for you. So we're sort of touching on these ideas already, but I think just a helpful summary here is, who does harm reduction help? It helps the people who are already engaged in treatment, right? Either by making sure that they have, that they're engaged in a way that's really helpful for pursuing the changes that they're interested in, or for making sure that they're aware of harm reduction strategies, if that's something that they're going to pursue. The people in their community and social networks, right? So people bring the knowledge that they get in treatment back into their communities. And I think that's such an important, again, we talk about both benefiting the individual and the community. The work that you do with someone in treatment can benefit their networks as well. It benefits the people who are not ready to stop using, right? We talked about that 40% and helping them get their foot in the door by saying, hey, we'll work with you even if you don't want to stop using. The people who say they're going to return to use, right, that client who's sort of like pushing back on us in the group and saying, I'm going to just go back after all this is done. And then the people who may want treatment someday, right? The people who, right, we're trying to help people understand that, treatment programs are a safe place to come to for help, are a reliable source of therapeutic relationships of trust and compassion and resources that can actually benefit their lives. And, that's, I think, in the same way, those harm reduction programs that are doing work with people who are using drugs and have no intention of making any changes around their substance use right now, they're keeping them healthier and safer and alive by doing the harm reduction work that they're doing with them, so that they may pursue treatment someday. So this is sort of a little roadmap of kind of where we'll go in the second half of the webinar as we get into some of the harm reduction strategies specifically for infectious diseases. So I'm not going to touch on too much of this right now, since we have more detail about it in the second half. But I will just say, so, one of the prevention strategies we'll talk about is regular testing for infectious diseases amongst substance-using populations. And what we'll see, or what we'll mention here and there, is this idea of opt-out testing. And so if you're not familiar, just basically that's the idea of making sure that testing is so regular and sort of just the default option for people that to not get tested actually requires a choice to not get tested, right? So opting out of testing is what happens, as opposed to just defaulting to testing everyone. We'll talk more about syringe service programs and how they also offer safer substance use supplies. And what does that even mean? Medications like PrEP and PEP for HIV prevention, as well as antiretroviral therapy and direct-acting antivirals. Those are for HIV and Hep C, respectively. And then medications for opioid use disorder, right? So those you're probably more familiar with, methadone and buprenorphine or Suboxone. And how does that impact someone's exposure to or ability to manage infectious diseases? So a couple kind of broad ideas here about substance use and infectious diseases, because I do see sort of a lot of overlap in terms of different characteristics of talking about these in general. So, the social determinants of health as a risk factor for both. So, right, understanding that social and economic factors make a difference in someone's risk of exposure to and their ability to manage both their substance use and also infectious diseases, right? That's a commonality that exists between substance use and infectious diseases. And again, that goes back to that biopsychosocial approach and the idea of a holistic approach, understanding that those other factors in someone's life, right, their ability to access health insurance, right? We saw that in the reasons why people don't seek out substance use treatment is they might not have the right kind of health insurance. And in the same way, that can make a difference in terms of people's risk factor for consequences associated with infectious diseases. Substance use as a risk factor for infection. So this is something we'll see over and over, and obviously we're focusing on specific infectious diseases today because substance use does increase people's risk for certain infectious diseases. In terms of treatment, so there's an intersecting likelihood of starting or adhering to treatment for both. What I mean by that is sort of what we were talking about at the beginning with physical health conditions, but ongoing substance use can be a barrier or complicate the process of receiving treatment, both for substance use or for physical health problems. And in the same way, kind of the other direction, physical health problems can complicate the process of accessing substance use treatment. The experience of stigma and its impact on treatment. So this comes up in a number of different ways, but, I think of specifically, one person I worked with, this is someone who had hepatitis C and polysubstance user. I would say primarily alcohol was his drug of choice, though. And I remember talking to him about seeing a doctor and getting treated for hepatitis C. And he said, I don't really deserve that. Someone else should get that instead. I think in his mind, maybe he was sort of characterizing treatment for hepatitis C as a zero-sum game. Well, look, we have these medications. We're going to be giving them to people. We want to give them to you, but that's not really the issue itself, really. It's this internalized stigma that people, I think both people with substance use and people with infectious diseases experience, which is, I don't deserve this help, right? I'm the type of person with a substance use disorder, so I shouldn't be helped. Or I'm the type of person who has this disease, and I got this disease because of, choices that I made maybe, or they feel that those sort of ideas in their head, that internal stigma, and it pushes them away from sources of help or pushes them away from treatment. Again, people are worried that identifying maybe with a particular condition can limit their opportunities. So there was recently a story about students being denied access to medical school because they had hepatitis B. And there was a whole ADA claim made around it, but it's this idea that certain infectious diseases, and I think substance use especially, could be a barrier to people accessing jobs or accessing other resources, like other opportunities in their life. And then I think kind of coming back to then the idea of, on the flip side, how do we work with people on substance use and infectious diseases? One of the ways that we combat stigma is by not shaming people, right? Not just like saying you're a bad person because this happened to you, but approaching people with dignity and offering them education and working with them to explore the different pathways to recovery that might work best for them, and kind of focusing on their own goals, and kind of whatever positive changes that can be made with regards to those behaviors. And I think another interesting thing is you'll see with some infectious disease programs that they've actually started employing peers, which is something you see a lot in substance use programs as well. The idea of working with peers lessens that stigma as well. And then this last point here about opportunities for reciprocal referrals. We know we're working with a common population, right, because of the risk factor of substance use associated with infectious disease. So harm reduction services can be an entry point to care, both for ongoing substance use treatment, but also for managing primary care conditions like infectious diseases. And then primary care settings can actually screen, maybe using SBIRT or audit deaths, that type of stuff, but can screen people for substance use disorders and then get them into additional services that can help in that way. So you see sort of like these worlds blending together here. So I'm going to move us to our next poll question here. So does your program currently provide testing for infectious disease? And I'll give you all about, we'll say about 30 more seconds to respond to this one. So the options here are HIV, hepatitis C, both HIV and hepatitis C testing, some other type of infectious disease testing, or none. And so as we're waiting for the last couple of responses to come in, you know, I think it's interesting, and we'll go through some of the, this is sort of leading us to where the material will take us next, but this is an idea that I think is becoming more and more common, is that because of this overlap between infectious disease and substance use, that programs serving people who use drugs or people who formerly use drugs are actually really important bases for doing testing and linkage to treatment for infectious diseases. So with that, I'll go ahead and close. We can go ahead and close the poll and check out the results. And so, oh wow, I have to do some quick math. I forgot how challenging this was going to be. So HIV and hepatitis C, there's 11 and 2, and then both HIV and hepatitis C, 22. So that's 35, and then 3 said other, and then 63 said none. So actually, interestingly, that's pretty close to what the national averages are. I'll just move us to the next slide here. So did you know fewer than 30% of substance use disorder treatment facilities offer testing for HIV or HCV? So actually, you all are pretty close to what the national average is. Sounds like a little bit higher, actually, than the national average in terms of offering testing for these infectious diseases. So I think that's pretty interesting there. So we'll get started. Before the break, I just want to get into a little bit of the detail. We'll start going through some of the information about HIV, and then we'll take a break probably in about a little over 5 minutes. So yes, so where we start is HIV, or human immunodeficiency virus. Probably almost never hear it actually said out loud because we're also familiar with the acronym at this point. But so HIV, just to sort of broad background, HIV works on the immune system. So it's a virus that attacks the immune system, mainly transmitted by anal or vaginal sex, but sharing syringes and other equipment used to prepare drugs for injection can also spread the disease. And so very often you'll see kind of the key target populations that HIV programs are often trying to connect with are men who have sex with men, and then kind of variations more specifically within that. And then also people who inject drugs, or those are some of the more common target populations for HIV prevention and treatment services. So there's some stages of HIV, kind of these are the stages as they're thought of. So there's acute infection, which is, shortly after being infected with HIV, people can develop flu-like symptoms. And sometimes people, don't even really think anything of it because, they think I have a flu, it goes past them, and, that acute HIV infection, oftentimes people are not really being caught or being diagnosed during that window of time. Excuse me. Then there's chronic HIV infection. So people can be asymptomatic for many years after being infected with HIV. And then when we say AIDS, there's actually not a real hard and fast rule to this, but basically it's when your CD4 count is very low, and then you start experiencing certain types of what do they call opportunistic infections. So things that our immune system are typically able to just fight off, you start getting sick with those opportunistic infections. And so CD4 count refers to your T cells, which support your immune system. And so, essentially you want your CD4 count to be higher. That means that your immune system is functioning really well. And then the viral load count, those are the two things that you're often being tested for when you have HIV to sort of monitor the status of your condition. Your viral load count it basically talks about the amount of HIV in your blood. So a higher viral load lowers your CD4 count faster and then increases your risk of illness, right? Because you have a weaker immune system and more of the virus. And then if you have a high viral load, it also increases the likelihood that you will infect other people. I think I'll just also mention here, if HIV is untreated and people have AIDS, that the survival is usually only 3 years. And so, there was for a long time this mentality of getting diagnosed with HIV was a death sentence, but that's really part of the stigma associated with HIV that still hangs around it, because HIV is very treatable now. It can be treated, and while there is no cure, there are definite, lifelong treatments available that improve people's health and quality of life, that keep their CD4 count up and essentially suppress their viral load to the point where, their viral load is undetectable and makes the virus practically untransmittable. And so we'll talk a little bit more about that as well. Here's just a map of what HIV prevalence looks like. As you can see, the darker red color indicates the higher, higher per capita rate of HIV. And so you can tell HIV prevalence is relatively high in Florida, and that's true, compared to the national average and to other parts of the country. Especially high prevalence in those major metropolitan areas in Florida, so Miami, Fort Lauderdale, Orlando area, and Jacksonville area as well. So I know many of you are working in those regions of the state. And then a couple quick stats that I pulled. Actually, so there's a lot of really great resources throughout this webinar. I'm not just saying that because I put it together. But floridahealth.gov has some really excellent resources on this. So these are stats from 2018 that I pulled from floridahealth.gov, which is 1 in 150 adults in Florida in 2018 were living with HIV. And then when you look by race and ethnicity, 1 in 292 white people were living with HIV, 1 in 156 Hispanics or Latinos were living with HIV, and 1 in 49 Black people were living with HIV. So you hear there sort of the racial disparity that exists in terms of the prevalence of HIV. It's almost the hour, so I think what we'll do here is just sort of pause, and we'll come back to this in a second, but when we come back, we'll talk about the HIV care continuum, or what's sometimes called the treatment cascade. So we'll go ahead and take our break now, and I think we can take a 5-minute break here. If there's any questions, I'll just take a quick look before we take the 5-minute break here. See just more so comments here in the Q&A box, basically the idea that failure is a part of making progress, which I totally agree with that. And then here we're talking about sort of the challenge of, Hep C treatment for people who are not sober. And I think that'll come into play also with this conversation about getting people linked up to treatment for HIV as well. Because definitely when HIV treatments started to develop, those are some of the same concerns, right? If someone's still using substances, how do we actually make sure that they're, following through with their treatment for this infectious disease? Great. So with that, we'll take a 5-minute break. Mark, did you want to jump in here?
Yeah. We'll go ahead and take that 5-minute break. We'll return sharply at 11:06 Eastern Standard Time. And if you have any questions while you think of them, you can go ahead and post them in the chat, and we'll get to answering those when we come back on the break. Does that sound good, James?
Sounds good to me. We'll see you all in a few minutes.
All righty. All righty. The time is now 11:06. James, you ready to proceed?
Great. Thanks so much.
No problem.
If you have any questions, anything that came up maybe in the first half or things that sort of popped up in your little 5-minute break there, go ahead and throw that in the Q&A. We'll keep an eye out for that, and then we'll keep moving. So as I mentioned just before the break, so the HIV care continuum, or sometimes referred to as the treatment cascade, is really kind of a 4-part approach to addressing HIV on a population level. And here the ultimate goal is what they call viral suppression. So if you'll remember, we talked about viral load, and viral suppression refers to when a person's viral load is managed by medication to the extent that they can be considered virally suppressed. So it starts with testing and diagnosis, and the recommendation is that all people aged 13 to 64 get tested at least once, but that people at high risk are tested annually. And so that includes people who inject drugs. Then being linked to care, and when they talk about linked to care in terms of what they're studying, they are talking about the idea that people are connected to HIV medical care within 1 month of diagnosis. That's the target for linked to care. And the care is antiretroviral therapy, or ART, which usually involves the use of 3 or more different antiretroviral drugs. So different medications that people would be taking. And then from there, the next part of the treatment cascade would be once you're linked to care, receiving or being retained in care. And so we mentioned the CD4 count and the viral load test. Those are the 2 different tests that characterize or that they're sort of used as the benchmark for someone being engaged in care. And so when they say received, that means you've had your CD4 count or viral load test within the past year. And then retained, which is the ideal, is that you have at least 2 medical appointments per year where you're getting the CD4 and viral load test, and that they're at least 90 days apart. So about twice a year, people should be going and getting this regular medical appointments and testing, and then keeping up with their medication. And then I mentioned here Ryan White case management. So for those of you who aren't familiar, Ryan White Care Services basically ensures access to healthcare supports for people who are HIV positive and have a low income. And then in Florida, that can kind of help cover costs and expenses associated with managing HIV, like doctor's visits, transportation, insurance premiums, case management, prescriptions, housing, than any other support services. So I have a link for Ryan White case management if you want to learn more about that as well. But Ryan White case management is definitely something that can help support people with staying engaged in care once they've been connected. And then I'll just acknowledge, in terms of the difference between being received or retained, the goal is to keep people retained in care, and the health outcomes are definitely significantly better when people are retained in care as opposed to just being receiving care. And then viral suppression. So when you adhere to the antiretroviral therapy and you achieve a viral load of fewer than 200 copies of the virus, that's when you're considered virally suppressed. And that is the ultimate goal of kind of the HIV testing, is that we find the people who are HIV positive, we get them linked into care, and then we help them stay in care long enough and maintain them in care so that they are virally suppressed. So I'll just say a little bit about kind of these HIV care continuum statistics here, because some of this stuff is what you'll see, oftentimes when people are talking about HIV. I just want you to sort of have some familiarity with this, so when you're seeing this language, you understand what they're talking about. One thing that I'll point out is, I guess as a starting point broadly, so you'll either hear people talk about prevalence-based statistics or diagnosis-based statistics. So prevalence is sort of what we're looking at here, which is of all the people with HIV. So based on our estimates and our knowledge, we believe that 86% of the people in the country who have HIV are diagnosed. That means there's about 14% of people who have HIV right now but do not know their status. And so then these statistics from the prevalence base are all based on that. So 64% of all of the people with HIV, including those folks who are not diagnosed, are receiving care, 49% are retained in care, right, have those 2 appointments in the past year, and then 53% are virally suppressed. And those numbers change slightly when you're just looking at the folks who are diagnosed. And the reason that they use those different statistics is, you know, basically there's different purposes and different settings where they're looking at different measures based on prevalence or diagnosis. I find most commonly people are reporting on prevalence-based statistics in the general things you'll see. As a comparison point, Florida actually does really well on some of these measures. So even though, you know, we saw that Florida is very high in terms of HIV prevalence, Florida also does really well in terms of HIV care. So 79%, this is for the most recent statistics, again, from floridahealth.gov, but 79% of people with HIV in Florida have received care in the past year. 72% are retained in care, and 68% are suppressed, have a suppressed viral load. So, you know, I think that's pretty impressive. Florida outperforms the national average in terms of managing HIV. What's interesting is all the people who inject drugs or people who have contracted HIV from injection drug users actually perform worse on all those measures. So again, I think that speaks to the need for us to sort of, for substance use treatment providers to play a role in helping people maintain or establish care, HIV care. I think a couple other things I'll just mention here. You don't see link to care on here because link to care is something that changes because essentially, you know, link to care is just a rolling average based on, you know, how many people were linked within the past, linked to HIV within a month of their diagnosis. So essentially the denominator is different from these statistics. So they don't usually see those statistics side by side. But just for a point of reference, in 2017, 78% of people receiving a diagnosis of HIV in the country were linked to care within a month. So, you know, the goal is always looking at those statistics, try to get them up a little bit higher. I think it's important to think about, well, what are some of the barriers that are preventing people from doing better on some of these measures in terms of being linked to care or being retained in care? And it's a lot of the things you would expect. So people experiencing poverty or people with inadequate access to transportation, people with health insurance limitations, unstable housing, right? Again, some of those both social determinants of health, but also some individual factors. So things like mental illness and substance use can be barriers to sort of establishing or maintaining care, as well as the stigma that we talked about before. Here's a quote from Dr. Eleanor McCants-Katz, who is the Assistant Secretary of Health and Human Services for Mental Health and Substance Use. And so the quotation here is, in this critical juncture of the HIV and opioid epidemics, substance use disorder treatment programs play a crucial role in ensuring those who are HIV negative remain negative, and those who are HIV positive are tested, linked to treatment, and able to remain adherent to antiretroviral treatment. So there you have it. Basically, you know, more and more you see people in these positions of authority acknowledging the really crucial role that substance use treatment programs can play in helping promote the health of people, either preventing the spread of infectious disease, but also promoting the health of people with infectious disease. So which element of the HIV care continuum does your treatment program currently provide or support? And I think you should be able to check more than one here. At least I hope so. So you should see the poll there on the right side. And again, thinking back to that treatment cascade of, you know, are you offering testing and diagnosis already? Are you helping people get linked to HIV care if they've recently been diagnosed with HIV? Are you helping people maintain care? So again, we talked about checking in with people about their physical health as part of their assessment, but is that an ongoing thing, right? You know, someone's goal might be to maintain viral suppression. What can we do to sort of support that process? And in terms of viral suppression, maybe that has to do with, you know, in terms of retaining in care, that might have to do with keeping up with appointments, whereas viral suppression might have more to do with, are we helping people keep their medications up to date and stay on top of taking their medications? So we can go ahead and close this poll question here. Just see what people think. So it looks like a lot of the work is really happening sort of on the front end. There's, some folks who are saying they're doing testing and diagnosis, a lot of people helping with linkage to care. So that makes me think that, a lot of you actually have a sense of where the resources already exist in your communities for HIV care, which is excellent. And then also some folks saying retained in care and viral suppression. So it sounds like, and for the folks who responded, the vast majority of you are recognizing that you have some role already in terms of maintaining someone's connection to HIV care in one form or another. That's really excellent. So I'm going to move us in now to talking about some of the strategies and harm reduction strategies specifically for managing or preventing HIV care. So syringe service programs, many of us are familiar with these, but basically the idea of a program that supplies people with sterile syringes or new and unused syringes, and these can often operate using an exchange model or a need-based model. And I point this out just to say, sometimes, essentially, when you hear syringe exchange, oftentimes what people are talking about is the idea that you have to bring in a used syringe as opposed to just going and being able to acquire as many supplies as you might need. And there is evidence that limiting the number of syringes dispensed actually decreases the proportion of people who inject drugs who achieve 100% of their injections with a clean, sterile needle, and thereby increases the risk of infection. So essentially, again, when we go back to this idea of how low is your threshold for accessing services, if the service that you're offering is, I'm going to give you clean syringes to inject drugs with, you're creating a higher threshold when you say to someone, but in order to access this service, you have to bring used syringes back to me, right? And so there's evidence that there are limitations to that approach in terms of the public health outcomes. So in Florida, the law was recently passed, and I believe the Florida law is, operating a one-to-one exchange. And so there's some limitations to that, but obviously, even though the law says, you need to receive, in order to receive one sterile syringe, you have to exchange it for a used one. So there's some limitations to that, but the fact that, Florida has now had syringe exchange for almost, I would say, I think it was back in 2016 that it was established, the first one was established, is a really positive development in terms of HIV prevention. And then some of the other things that, some of the other benefits of syringe service programs is that they prevent public discarding of used syringes. So they did a study in Miami where they looked at after a syringe and needle program was established, that there was a 49% decrease in unsafe disposal of used needles and syringes after the program opened. Other things that the syringe service program might provide, in addition to injection equipment, and this is really important, in addition to the sterile syringe, is other injection equipment. And so this helps with other aspects of vein care and injection health, but also all of these different surfaces and paraphernalia can be carriers of infectious disease as well. So reusing things like cookers or cooking or surfaces, not having sterile water, sterile alcohol pads to clean surface areas or to clean injection sites, all of those things increase the risk for infection as well. So syringe service programs, in addition to offering these supplies, will actually teach safer injection techniques. And there's a citation there in the resources. Again, if you're interested, there's a lot more detail I could go into, but will not right now, on how to inject in a safer way. Again, it might sound foreign, but there are more and less safe ways of injecting drugs. And so I think that's, an important base of knowledge for us to have, and that is offered to people in syringe service programs. And then lastly, that syringe service programs are an entry point to care, lead to referrals for primary care, mental health, and substance use, and other social services. So see here some of the benefits. Again, syringe service programs are associated with a 50% reduction in HIV and hepatitis C incidence. So essentially, new infections of HIV and HCV are decreased in areas that have syringe service programs. That new users of SSPs are 5 times more likely to enter drug treatment and 3 times more likely to stop using drugs. So again, like I said, these harm reduction programs really are, in some ways, a referral source for the substance use treatment programs that many of you all are working in. And then as these SSPs distribute more syringes, it's more likely that people who inject drugs are going to dispose of syringes safely, right? They have a place to to discard used syringes now when there's an SSP operating in their community. And that the people who access SSPs are more likely to use condoms when compared to people who use drugs but don't go to SSPs. So again, that just sort of speaks to this idea of it's not just that they're offering syringes, but they're offering other opportunities to reduce harm in people's lives. So it's maybe not just the spread of infectious diseases, but also other STIs, in addition to things like preventing HIV or hepatitis. HIV testing as prevention. So important here, we talked about sort of that treatment cascade, and we recognize there are some people who don't know their status, as well as people who might know their status but aren't actually engaged in care. And so 40% of the new HIV infections are transmitted by people who don't know they have the virus. And then when you add in the people who know they have the virus but are not retained in care, that number goes up to something like 80%. So the vast majority of HIV infections are happening from people who either don't know their status or who aren't engaged in care. So that's a big part of why testing is just so important, is making sure people know their HIV status. And then the goal is to implement testing in appropriate settings and then rapidly link people to treatment. And as time has gone on, we now have easier forms of HIV testing that increase the opportunity for more widespread testing. So you see here, SAMHSA, wrote a letter on this topic, and basically this is sort of their guidance on the idea of HIV testing, which is SAMHSA encourages substance use treatment programs not currently doing HIV testing on site to integrate HIV pre- and post-test counseling and oral fluid rapid HIV tests, and to make this a routine component of substance use disorder treatment. So if you're not familiar with some of the testing, oral fluid tests are able to detect HIV antibodies. Blood tests are able to detect HIV a little bit sooner. So if someone had a more recent exposure to HIV, they might want to do a blood test. But oral fluid is definitely effective. And then in terms of, what blood tests look like, it's usually a finger prick is one of the rapid tests that you can do. And so I think, some of you might be working in treatment programs that are either connected to clinics or that have labs on site, or someone who does maybe like your urinalysis. So you might actually have the capacity for other types of HIV testing, but the oral fluid test is definitely very accessible. And so just helping people know their status and getting them linked to care is just a really, really important function that substance use treatment programs can play in this work. HIV prevention medications are also an option. So there's PrEP and PEP, pre-exposure prophylaxis, and then post-exposure prophylaxis. PrEP is a daily medication that's taken by people who are at risk of getting HIV. And when taken daily, it's effective at both preventing HIV from sex or injection drug use. And then I just added this, so sometimes you might hear PrEP. I feel like most people talk about PrEP as, you'll just hear people say PrEP, but sometimes you'll also hear the brand names Truvada or Descovy. So if you hear those, right, if someone tells you those are the medications they're taking, that's what that's for. But what they've found is actually the knowledge and access to PrEP is lower among heterosexual people who inject drugs. So I think there's been a heavier emphasis on getting PrEP into like LGBTQ community and not as much exposure in terms of injection drug community. But still very effective. PrEP is very effective at preventing HIV transmission in that sense. And then post-exposure prophylaxis is if someone has been exposed to HIV, a medication that people can take to prevent the disease from reproducing. So basically, it must be started within 72 hours and taken for 28 days, and then it actually prevents HIV. And then essentially part of the kind of like signs that someone might be appropriate for PrEP is if they've used PEP multiple times, right, because they've been exposed to HIV, it's probably a good time to like have a conversation with them about the idea of getting onto PrEP as an ongoing preventative measure. Again, here you'll also hear this idea of sort of treatment as prevention for HIV, because part of what happens with HIV medications is if we can get people virally suppressed, we know that actually prevents the likelihood of them passing on the disease to someone else. So again, here's that individual and community idea coming back. It's better for the individual to have viral suppression, also better for the community. I also mentioned, medications for opioid use disorder like buprenorphine and methadone. They have been proven, there's an association of taking those medications and improving adherence to antiretroviral treatments, so the antiretroviral medications, and achieving viral suppression from HIV, and then also reducing HIV and HCV transmission. So it sort of makes sense also that, right, as people adhere to treatment, reduce their viral load, that they're going to reduce the spread of HIV, but also reduce the spread of HCV, hepatitis C in this case, in part because, what's happening is by switching to the medication for opioid use disorder, they're less likely to engage in the illicit drug use. And then this point here, undetectable equals untransmittable. That's like a public health and awareness campaign that you may have come across. But again, that's sort of getting at this idea of if people get to an undetectable viral load, that we want them to know that means that it's very unlikely that they're going to pass along the disease to someone else, and it's going to improve their health and quality of life as well as someone who's living with HIV. Yeah, so I think that's all I have to say about this one. I'm going to move us on now to the viral hepatitis stuff. So essentially, hepatitis is a liver disease, and most commonly we talk about hepatitis A, B, and C because those are the most common. Hepatitis A is a short-term infection, still very unpleasant, can lead to hospitalization. Hepatitis B and C can become chronic. In all cases, people who inject drugs, or really people who use drugs in general, are at a higher risk of getting viral hepatitis, and also heavy alcohol users as well. And basically, what we're finding is that the opioid epidemic and then increasing rates of injection drug use are propelling infections with regards to hepatitis. Just in terms of transmission, you see here a couple of notes about that. So hepatitis A is fecal oral, which means essentially contaminated food or water. Essentially, people not sufficiently washing their hands can be part of what passes on the disease. So someone with hepatitis A doesn't wash their hands enough in the bathroom. It gets on food or water or, drug paraphernalia that they're sharing with someone else, and that can spread hepatitis A. Hepatitis B, sort of similar, where sharing drug equipment. So again, this isn't the fecal oral route, but because of blood transmission. And I think an important distinction with hepatitis from HIV is, with hepatitis C especially, it's more concentrated in the blood, and so that makes it easier to pass on. And it really sticks to surfaces in a way that makes it really risky in terms of ongoing transmission. Some of the symptoms, I won't go into too much detail about all this, but basically symptoms you'll see for some of these with like Hep A and Hep B are things like fever and yellow skin and things that might not necessarily be readily distinguishable from other conditions. But again, when people get sick and can stay sick for several months with a hepatitis A or hepatitis B infection, that would be an opportunity. You really need to go to a doctor to get tested to figure out if you have it. In the case of hepatitis A and B, the most important thing to do is get vaccinated. That actually prevents people from getting those diseases in the first place. And while there's no vaccine for hepatitis C, there is a curative medication for hepatitis C. So we'll talk more about that in a second as well. I want to just work through some of these maps to just give you a broad sense. Florida is heavily affected by hepatitis, in all these different strains that you see. So here's hepatitis A outbreaks in the country. And I'll just say, hepatitis A has increased significantly in recent years, like over the last 5 to 10 years, roughly. And there's been outbreaks across the country, but in Florida right now as well. Here's hepatitis B. Again, you can see Florida heavily affected in terms of acute hepatitis B infection. And so just to clarify here, if you're not familiar, so there's acute hepatitis B and then chronic hepatitis B. In infants that get infected with hepatitis B, it's very likely that it becomes chronic hepatitis B. When adults get it, most adults are able to sort of pass it, but about 5% of adults end up developing chronic hepatitis B. And in all these cases, like I mentioned, hepatitis is a liver disease, and so it can cause serious health problems like liver damage, cirrhosis, and liver cancer. And then, I don't know if I mentioned already, but basically hepatitis B, in terms of hepatitis B infection, one of the most common risk factors is injection drug use. So here with hepatitis C, what we know is hepatitis C, again, you see Florida pretty significantly impacted by hepatitis C. When hepatitis C becomes chronic, about anywhere from 5 to 20 or 25% of the time it becomes cirrhosis. Hepatitis C is actually the leading cause of cirrhosis and liver cancer in our country. And so that, again, sort of speaks to some of the challenges of these infectious diseases. So I'll move us here to some of the trends and developments, and I've touched a little bit on this already, but basically there's evidence that suggests that the recent increases that we're seeing in HCV, hepatitis C is the acronym here, are associated with the opioid epidemic. So basically, what appears to be the case is that the majority of new hepatitis C infections are due to injection drug use. And the reports of HCV cases have increased significantly in the past 10 years. And there's also been a shift, though, in terms of who is being affected. So, 10 years ago, the focus was much more on baby boomers as being likely to have HCV. But now we're seeing more young adults, that age range of 20 to 39 is having the highest incident rate. And again, that goes back to kind of changes related to the opioid epidemic. And then there's also dramatic increases occurring in rural communities. So I think that's a kind of another shift that we're seeing. On the more positive trends and developments, recent years have also seen the release of direct-acting antivirals. So, if you've been around for a while, you've probably heard of like interferon, and that was the older way of approaching treatment for hepatitis C. There's a lot more side effects. In order to get screened for getting interferon, you had to go through a liver biopsy. There are non-invasive approaches now that don't require the liver biopsy to getting started on direct-acting antivirals. You only take these medications for a shorter period of time, something like 8 to 12 weeks, depending on the medication you're taking. They're very effective and fewer side effects. And I think that sort of helps with the kind of cost-benefit analysis of pursuing treatment for hepatitis C. Is it used to be a much longer time commitment and more significant side effects that people had to accept the risk of if they were going to get treated for hepatitis C. So, similar to HIV, there's this treatment cascade when it comes to HCV. And then the main risk is kind of the difference here between HIV and HCV is HCV is curable. So then, instead of just achieving viral suppression, you sort of you achieve the cure for Hep C, and then the goal is to prevent reinfection. And so that would include things like linking people to harm reduction programs, right? Again, making sure that if they are still using, that they're using in the safest way possible, or making sure that they're linked to substance use treatment programs to help them maintain abstinence if that's their goal. So I think the other thing I'll just mention here in terms of treatment is, someone mentioned before the challenges of sort of helping people. Someone mentioned depression with interferon treatment, and that's definitely one of the more significant concerns. So I think in terms of supporting people with HCV from treatment programs, one of the things we can do is dispel some of the notions about what HCV treatment looks like. And so that includes making sure people know interferon is not your only treatment option. And so we want to, help educate people. I think that's part of the work that treatment providers could be doing, is educating people about the new options for HCV treatment. And similar to the treatment cascade, about like, once people get on those treatments, how do you make sure that they're following up with it to make sure they complete the course of treatment? And maybe that includes, well, I mean, if you're in an OTP setting, you might actually be able to directly observe someone taking their medications. So direct observation would be an option in some cases, but certain things like, external reminders to take medications, helping make sure people have pill boxes or apps on their phone to like help them remember to take their medication, or even just having a conversation with people about how they're taking their medication. It's interesting, like all these positive changes, things that you can do to help someone, stick to the medication, stick to the plan that they have. I think of all of those, there's really just like minor harm reduction strategies, right? So every time, we're helping someone prevent missing a dose, that's a little bit of harm reduction right there. So drug treatment providers in hepatitis. Here's from the Institute of Medicine. This is part of the National Strategy for Prevention and Control of Hepatitis B and C. So it says drug treatment and needle exchange programs reach a substantial portion of active injectors who have HCV infection or are at risk of acquiring it. Because the programs have regular long-term contact with many injection drug users, there are multiple opportunities to disseminate information about hepatitis B and hepatitis C, including the benefits of hepatitis B vaccination, how to avoid reinfection with HCV, and the importance of follow-up care for those chronically infected. So again, really important resource, and you all are just such an essential touch point for helping to control the spread of these infectious diseases and the problems associated with these infectious diseases. So prevention, testing, and treatment for viral hepatitis. Again, sometimes we think about harm reduction as sort of these big programs or big strategies, but something as basic as practicing good hygiene, really good hand washing, can be harm reduction. And especially when we're talking about the risk of spreading hepatitis A, just making sure you really wash your hands sufficiently when you're going to the bathroom. I mentioned before, but basically vaccines are the most effective thing for Hep A and B because it prevents people from getting it. And then making sure people have sterile equipment if they are using drugs. What we also know about vaccines for Hep A and Hep B is typically people who use drugs have less access to these vaccines. So that's why it's important that we figure out where people can access these vaccines and help them get connected to it. In terms of testing for hepatitis C, it's recommended for all adults 18 years or older at least once, but also for people who are pregnant, and then people with other risk factors such as history of sharing syringes or other drug preparation equipment, or people using intranasal drugs. So kind of like ongoing testing recommended for those folks as well. And then this is really important, and someone sort of touched on this idea already, is the idea that ongoing injection drug use should not be seen as a barrier to HCV treatment. And in fact, if someone is still actively injecting, that's someone who we really want to get HCV treatment, because if they can get treated and cured of HCV, that reduces their likelihood of then passing it along to someone else. And so I've seen where people have been denied treatment for hepatitis C because either they're actively using alcohol or they're actively using drugs. And what we know is that there is no medical or scientific evidence to support sobriety requirements, right? So essentially, insurance providers or healthcare providers even might implement a guideline or a rule that says you need to stop using all alcohol or drugs for X period of time before we'll give you this treatment. And I think, when we talk about stigma, this really comes back to that idea of, what are we denying people, right? If we're saying you have this disease, we have a medication for it, we're not going to give it to you though, right? Not because the medication won't work because you're using drugs, we're not going to give it to you because, what, we don't think you'll actually take your medication? We don't think you'll, I mean, what does it say to people? It's no wonder that people have this internalized stigma of saying, do I even deserve this help? Because in some ways we have systems set up to say, no, you don't deserve this help if you're still using substances. And I understand the concern. You know, people will say, well, if someone's using alcohol or drugs, they might miss a dose of medication. And even people who are not using alcohol and drugs miss doses of their medication. So, but that point aside, you know, the same things were said about HIV treatment originally, which is, oh, well, you know, if someone's homeless or if someone's using drugs, we can't give them HIV treatment. It'll be wasted on them. They won't be able to follow through with it. And the reality is, if you put the right supports in place, people who use drugs can and do adhere to treatment for HIV, for Hep C. And so really the question isn't, you know, should we be giving the people the medication for their condition or not? It's what supports can we put in place to help people maintain their connection and follow through with their treatment for this condition. And I really think that's, again, where treatment providers can be a really valuable support in terms of helping people successfully engage and maintain their connection with care. I've looked this up recently. So Medicaid in Florida actually requires 1 month of abstinence. And again, like I said, there's no evidence that sort of supports that barrier. And I do think that sort of amplifies the stigma. But what I will say is what the trend has been in recent years across the country is that those restrictions are actually getting lower. So that at least is a positive sign, is that we're reducing the barriers for people being able to access, you know, the healthcare and treatment services that they need and deserve. I'm going to keep it going here. Oh, there we go. I mentioned safer substance use supplies. So very often when we think about safer substance use supplies, we're thinking about syringe services. And I think it's important that we recognize that there are non-injection drug users who are also at risk of spreading infectious diseases. A lot of this information comes from the California Department of Public Health Office of AIDS. And they put out this guidance recently about other safer substance use supplies. And it's the idea that, you know, non-injection drug use equipment, so people who are snorting or smoking, are also at risk of spreading infectious diseases, and in particular Hep C, to one another. And that's because, like I said, you know, the disease is so concentrated in the blood that, and the disease stays on surfaces such that someone really can spread the disease just by something simple, like you use a straw to snort, and it causes a small cut inside your nose, something that's not even really particularly noticeable. But when you pass that straw to someone else to snort, like right after you, that is something, or you're reusing straws, that is something that can actually increase the likelihood of someone getting another disease like HCV or other diseases like tuberculosis as well. So some of the supplies that harm reduction programs might distribute along with syringes include straws, plastic cards, scoops, or vitamin E is to help heal certain cuts. And then in terms of smoking equipment, so if you think of people who are smoking rock cocaine or methamphetamine, glass stems, pipes, rubber bands or stoppers, steel wool for the filter inside the glass stem, and alcohol wipes. And I will tell you, if you talk to your folks who use drugs, they can teach you about this stuff, right? They can let you know, oh yeah, well, I know why you would use those things. But more or less in terms of the glass stems and rubber bands and stoppers, you know, when you put your lips to a hot pipe, that can cause cuts and blisters and, again, expose, you know, the smoking equipment to blood. And so you want to reduce the risk of that by making sure people have their own glass pipes, or making sure that people have rubber stoppers to prevent burning and lips and blisters and cuts. And again, there's basically evidence that shows that this is going to reduce sharing and reduce the drug-related health problems associated with it. And I think it's also an important strategy because I think harm reduction programs, and I'm seeing this here with some of the programs here in Illinois, are really trying to offer these supplies as a way to open themselves up to more folks, right? So if people just think of harm reduction programs as syringe service programs, there's a big portion of the population, people who say, well, I would never use a needle, but they're snorting and smoking their drugs, who are never going to access those programs. Really important that they are kind of broadening the resources available to that group. So other infectious diseases, so things that probably we're familiar with a little bit, obviously tuberculosis, a pretty common one, it affects the lungs, spread person to person through the air, and then skin or blood test for TB infection and a chest x-ray to confirm. And then the treatment is pretty lengthy, but 6 to 12 months of medication will treat and cure tuberculosis. And then endocarditis I want to mention because this one doesn't get a lot of attention, but it's a bacterial infection affecting the heart. And the symptoms include flu-like symptoms, fatigue, shortness of breath. And the way that it's transmitted is by entering, basically some type of bacteria enters your bloodstream. And that can happen with injection drug use, right? If you have dirty supplies, things that are being reused, including the syringes, but also cookers, a lack of sterile water, those types of things. And it can be treated with antibiotics or surgery in more extreme cases. But the reason that I highlight this is a really significant health threat to people who inject drugs. And so models show that by 2030, endocarditis could kill 1 in 5 people who inject drugs. Right, we're talking about this sort of like massive threat to, the people who are using drugs who we care so much about. And so again, this really goes back to why it's so important that for those folks who are still injecting, that we find a way to connect with them and make sure that they have harm reduction resources available in their community, that they have the information like the CRA, Chicago Recovery Alliance information that I mentioned before about best injection practices. So here we go with COVID-19. I'm sure you all have heard more than enough about COVID-19, and there's no map for this one because the map it's bad all over, and it kind of keeps on seeming to get worse at this time. But what I do want to highlight specifically about COVID-19 for this group is the connection between COVID-19 and substance use. So there was a study done recently to analyze electronic health records for patients, and what they found were sort of an association between substance use diagnosis and not only COVID-19, but also worse health outcomes with COVID-19. So you see here, individuals with a recent substance use disorder diagnosis, so in this case, they're talking about within the past year, they've got a substance use disorder diagnosis, have an increased risk for COVID-19. And this is especially the case with individuals with an opioid use disorder and African Americans. So just to clarify, so African Americans with a substance use disorder have the highest risk by race. All people with an opioid use disorder, and even more pronounced when you're looking at African Americans, but all people with an opioid use disorder have the highest risk. And then it's followed by tobacco use disorder, alcohol use disorder, cocaine use disorder, and cannabis use disorder. And so you see the disparity in terms of the increased risk for COVID-19. But then especially concerning is that people with substance use disorder and COVID-19 had worse outcomes. So over there on the other side of the slide, you'll see in terms of hospitalization, patients without a history of substance use disorder, 30.1% were hospitalized, whereas 41% with a history of substance use disorder were hospitalized. And then in terms of cases of COVID-19 resulting in death, 6.6% of people without the history of substance use disorder resulted in death, whereas 9.6% of people with a history of substance use disorder and COVID-19 resulted in death. And so, the thing that this study highlights really is any strategy that exists right now for addressing the COVID-19 pandemic should also be screening and treating individuals with substance use disorder. So, wherever the testing sites or programs exist in your communities, it's important that those folks know that you all are out there providing substance use treatment services, because making sure that substance use treatment services are available and accessible for people is particularly important at this time. In terms of why is this association happening, again, we don't know for sure, but what the authors sort of suspect here is there's higher prevalence of comorbidities. Some of the things we know, certain things like asthma, the health conditions basically that increase people's risks associated with COVID-19 are more common with people with substance use disorder. So those risk factors are more significant. And so I think all of that kind of brings us to the sort of question of, well, what do we do to adapt, right? We're facing these unprecedented challenges associated with COVID-19. So I do, before I get into kind of some of the things that I've seen going on around the country, I do want to give you all a chance to just sort of chime in. What changes have you made in your programs and practices related to the COVID-19 pandemic? And you can go ahead and add those in to the chat. Yeah. Yes. So a couple of the things that we're seeing here, some of the adaptations are, it is more difficult to maneuver and manage our relationships with people. There's more telehealth involved in terms of how we're engaging with people. Increased cleaning, yeah, absolutely. Less community visits, asking about wearing masks. So yes, telehealth and reducing face-to-face contact, which, in some ways I think has made certain aspects of treatment more accessible. So obviously, virtual appointments for medication-assisted treatment, being able to get prescribed buprenorphine over the phone, that is helpful. And so much, like we talked about early on, so much of substance use treatment is about therapeutic relationships and engagement and connection. And, for all the Zooming and WebExing and Skyping that we can do, there is a difference between being in the same room, in the same place with someone. The feeling of trying to connect with people is different when we're doing it through a computer. And I think it's important that we acknowledge that, and it does make the work more challenging. Some of the other ones we see in here, adding in PPE for staff and clients, so making sure people are masked up and trying to be as safe as possible when we are seeing people important. So some of the difficulties of in terms of housing challenges for people, I think, yeah, it sort of exacerbates that as well. Curbside medication, limiting the number of patients who are allowed to come in. I think these are all like really important strategies and just everything we can do to try to keep people as safe as possible. Yeah, thank you so much for those suggestions. And we'll see a few of these things have been added in. So just broadly, harm reduction and treatment in the era of COVID-19. So enhanced safety precautions, right? We're talking about the things people have talked about, more cleaning, more masks, temperature checks, really being as familiar with people's physical health condition as we ever have been. Adding flexibility to operational guidelines. I have a few examples of that I'll share. Bulk service delivery, so when we can, making sure people get as many supplies of whatever they need as possible. Digital support, so that's the telehealth, but also a lot of peer recovery has moved online as well. And then sort of some changes in terms of what overdose education and naloxone distribution looks like in particular. And I'll actually be doing another webinar early next year on naloxone and overdose prevention. So hopefully I'll be seeing some of you all or speaking to some of you all again at that time. So here's some of the increased flexibility from some of the larger systems in terms of how our systems are adapting to try to make services more available during the COVID-19 pandemic. So SAMHSA issued guidance to opioid treatment programs, OTPs, that allows for blanket exceptions for stable patients to take 14 or 28-day take-home doses of methadone. So more access to longer take-home doses. And I think that's been really helpful for some people to avoid the frequency. And again, when we talk about like bulk delivery of supplies, instead of having to come into a clinic every day or every couple of days to pick up methadone, to only have to do it once or twice a month, I think really reduces people's risk of exposure, not just for the patients and the clients, but also for the staff as well. the DEA relaxed the rules to allow for prescription of buprenorphine for maintenance or detox, for detoxification treatment following a phone evaluation. So again, just making medication for opioid use disorder, and obviously we know about the benefits of buprenorphine in terms of reducing people's risk of overdose, but also reducing people's risk of ongoing illicit substance use. But then we mentioned improving people's outcomes in terms of managing infectious diseases like HIV or preventing the spread of HCV. So that, I think, is really a help there. Then Health and Human Services implemented changes in telehealth that allows providers to use remote communication technologies that may not fully comply with HIPAA rules. So there's been a sort of relaxing around those rules to allow for the use of FaceTime, Skype, or Zoom. Now, you can't do your sessions on Facebook Live or something like that. There are still some limitations in place around that, but it definitely made it more available in terms of the options for working with people on some of these things, right? So I don't know if anybody here knows how to use TikTok, but you cannot do counseling via TikTok in spite of these changes. Okay. And then Florida specifically allowed out-of-state healthcare providers to work in Florida and via telehealth. So then they extended the renewal timelines for professional licensure. So all of that, I think, comes back to this idea of how do we make services as available as possible, more things for more ways to engage with people, more flexibility around who can serve people. And I will, we have to acknowledge our systems are trying to make these, I think it's an acknowledgement of how important substance use treatment is in all these changes that you're seeing, right? There's this, we know this helps people. We have to make sure we keep it available for them in spite of the ongoing pandemic. The last thing here, so some of the safety precautions, and there's some really great resources that I think anybody could use a lot of these, but Vital Strategies put together a whole list of resources for different types of harm reduction programs. And so I picked out some of the key points, but providing educational material about COVID-19, especially depending on the population you're serving. If you're working with folks who are homeless, they may not have access to updated information about COVID-19. So being a resource on that information, and I think especially with what we know about the overlap of risk between substance use disorder and COVID-19, I think that's helpful information to get out in the community. Administering or linking to vaccines for flu, hepatitis A, and hepatitis B. So helping people manage those other infectious diseases to make sure they're not dealing with kind of compounded health problems that could land them in the hospital at some point. Hand washing, coughing into tissues or elbows. Those are some of the suggestions I heard you all using as well. Distributing hand sanitizer or the PPE, personal protective equipment, one of those acronyms we've all become so familiar with. And then offering extra safer substance use supplies. So I've heard of, syringe service programs that are now giving people more syringes when they're allowed to, of course, but giving people more syringes when they come in for services. Or if they come in for a naloxone kit, give them 5 or 10 because you don't know when you're going to see them again. And there might be people in their network who they can share those supplies with as well. And again, similar to methadone, it reduces the frequency that people have to come back to restock. Again, supporting medication continuity, so making sure people have prescription refills when you're working with them. And that can be for things like buprenorphine, but also for, psychotropic medications, mental health medication, physical health medication, making sure that people have refills so that, again, cutting down the amount of follow-up visits they would have to do with a healthcare provider. Staffing changes, and so one thing that I've seen with some programs is making sure that the people who are at a higher risk of exposure or who have more pre-existing conditions that could expose them to worse health outcomes associated with COVID-19, that those folks actually move into kind of different roles where they might not be in client-facing positions. So I think that's an interesting way of shifting to protect against COVID-19. And then virtual and outdoor training or distribution of supplies. Obviously, we're heading into winter here in Chicago, so that's going to be a tricky thing to adapt to. I know in Florida, my parents are down there, and I think they said, my father said they're heading into a cold spell, so it's going to be under 80 degrees this week in South Florida. So maybe some outdoor work can still be possible a little bit longer in Florida than it is up here in Chicago. And so you see like a lot of different ways of adapting here to COVID-19. So we're at the end of our time, and I'll just go ahead and say, like I would just ask you all as you're heading off to, get back to work today or wherever you're heading from here, take a moment before you get back to things to just sort of reflect on some of the material that we went through today and just try to think about what's a big takeaway that you have and one thing that you can start doing in your work to either help prevent or treat infectious diseases. And we talked a lot about maybe different ways of incorporating harm reduction into your work, different ways that you can support people either by starting to offer testing or helping people to find out about their status with regards to these infectious diseases, finding out if people are engaged in care or helping them get and stay engaged in care, all these different ways that you can be part of trying to help protect and support your population around these infectious diseases. And so with that, I will just say thank you all so much for what you do. Your work is honestly just more important now than it ever has been. And so I'm so grateful for all the people out there who are persisting and carrying on to do this work in spite of all the new challenges you all are facing. So with that, I'm just going to walk through some of the references and resources as we wrap up here so you can see those in the recording.
Oh, well, thank you, James. That is a nice touch. If you want to go ahead and just scroll through those. And the PowerPoints, again, they will be available online within 30 business days. And that was a very beautiful presentation. Thank you very much. I'll let you scroll through some of these slides, and then we'll go ahead and wrap up.
Yeah, thank you all so much. And I mentioned many of these resources sort of throughout the webinar. So really great resources on helping people get connected to whether it's PrEP for HIV prevention or HIV testing and treatment, Hep C testing and treatment, all of that you can find in here, as well as, resources for finding harm reduction programs and naloxone distribution in Florida, for learning more about HIV and the efforts to prevent and treat HIV, you can go to floridahealth.gov. So just really a lot of really great resources out there. And then you'll see some of the other references here as well. And yeah,
perfect. Thank you. Yes, and that was a perfect touch adding those references there. We appreciate that very much. Please note a couple of items of business before we conclude today. When I conclude the webinar, your browser will take you to an evaluation on FATA's new website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE broker for the Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you will be directed onward to an evaluation. You may consider using the same email address when you register for webinars through our WebEx link and when you set up your profile in FATA's system. This helps connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today in about 30 minutes. The sender will be messenger at WebEx. Evaluations will close midnight on Thursday, November 19th. We do not email statements of credit. Instead, after we verify attendance and completion of evaluation, a statement of credit will be generated as a journal entry within your profile. Thank you for participating in today's webinar. We'd also like to recognize and thank especially the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day, and please hold for the evaluation.